Good morning, everyone. Welcome to another session of the Endocrinology Grand Rounds. We are very, very fortunate to have one of our own today, Dr. Leila Khan. Dr. Khan is the medical director of the Calcium Parathyroid Center, has been with us for about 15 years.
Yes, 15.
15 years, and it has been wonderful to see the growth of the Calcium Center with collaborations across different institutes at the clinic. And now are you collaborating with Abu Dhabi yet?
Yes, we are.
Perfect. And also the growth of Dr. Khan as a leader in this space. We are also very fortunate to welcome Dr. Makin today, Vice Chair MSI from Cleveland Clinic London, who's joining us for a visit. Dr. Khan.
Thank you so much, Dr. Makin, for that warm introduction. I'm delighted to be here today. I'm going to be discussing bone biology for the clinician. This is fairly laid back, so feel free to stop me through the way. So I have no disclosures today. This is kind of the broad outline of the talk. So bone is a dynamic living entity. I think it's really important, especially for the fellows in the room, to really stress how important that bone is living. And so you have different types of bone. You have compact cortical bone, predominantly like in the forearm, and then cancellous bone in the vertebrae. It's essential for many functions in the body. So you could divide it into 4 categories, 4 very general categories. So it harbors the bone marrow. It is essential for locomotion. It helps with the soft tissues. And then, of course, it also regulates calcium, phosphorus as a reservoir. So bone is really, really important. And I think it's important to recognize that it's living when we try to take care of our own bones. So when I was putting together this talk, I didn't realize how much of building and remodeling our bone is actually doing. So every year we actually repair about 10% of our bone, and every decade we almost replace the entire skeleton roughly. And so we have primary building of bone, and then we also have remodeling of bone. And I think it's important to recognize some of those differences. I'm just going to minimize that. And so basically, we'd like to think of bone density as a reflection of the strength and the quality of bone, but it's not really that straightforward. We don't really have a good adequate way to understand the quality of our bone, short of doing a bone biopsy. But basically bone quality, you can gauge it in many ways. For example, clinically, if someone's fracturing or not fracturing, genetics are key, and different envelopes that you can make primary building and then also remodeling the bone. And I think, discussing bone biology is important because when we're choosing drugs for our patients, it's important to remember kind of the pathophysiology of these different mechanisms and why one drug may be more beneficial than another. Yeah. So this is kind of just showing a brief kind of web of how all these different parts are connected. One could really dedicate one's entire career to kind of studying this, and many people do. There are several bone biologists in the country, and but there's an interrelated web of osteoclasts. We have osteoblasts, which are the bone building drugs, and then osteocytes, a lot of different factors which are important. And this is why in the past 15, 20 years, or even dating back to 1990, we've been able to really have nice treatments for bone health. So I just wanted to pause and discuss bone modeling and remodeling. So the primary formation of bone is reshape and increase bone mass. There are 3 different envelopes that are important. You actually have either in the modeling of bone, you have osteoclast or osteoblast. You don't have, there are different envelopes that are working on it. And then you can you do this throughout life and increase your bone mass. With remodeling, which is extremely important so that we can maintain a healthy skeleton, we're renewing our bone. Like I mentioned, every year we renew about 10%. There are actually 4 different envelopes that occur, and you have sequential osteoclastic activity followed by osteoblastic activity on the same surfaces. So it's a little bit different, again, also throughout life. And then, you can actually not only increase, you can also decrease bone mass too. So this is a cartoon which kind of models the formation, which is in yellow, and then the resorption modeling, which is in gray. And basically through these different factors, you can really have a nice healthy skeleton. And so, is there a question? And so basically, with exercise, for example, if someone's taking up tennis, they're right-handed, you're going to actually have a pronounced improvement in your bone density just by that activity, that you can control. So I think, in endocrinology, reason like 998 would be also to improve your bone strength. So it's not just, helpful for, our diabetic patients, it's helpful for each and every patient, particularly those with issues of bone health. And I've been really stressing this in the office to people. I think it's important not to overdo the workouts, but if you can even walk, my mentor, Mara Horowitz from University of Pittsburgh would always say, when you go against gravity, you're actually building a bone. And so, you can really have some control and some improvement in your bone densities, to a degree. A lot is controlled by genetics and, of course, secondary issues as well, which we could spend another day talking about. But, exercise is really, really critical.
Can I say something?
Yes.
There was a study looking at the college students, females, and they looked at the bone density. So the gymnasts who were the smallest bodies had the highest actually bone density in the lower spine and hip. And then the non-athletes who were in the middle, they was kind of average. And then the swimmers who were physically the biggest had the lowest bone density because they spent about 25 hours a week in the swimming pool, which is kind of weightless. So that's kind of the importance of mechanical low density.
That's interesting.
Yeah.
Yeah, so thank you so much for mentioning that. So weight-bearing exercise is the goal. Although I will tell people anything to move, because I think we all know in Cleveland, many of our patients, some of them barely move, just go through the stairs once or twice a day. I mean, it's really quite.
I think something is better than nothing.
There's
Stop
also
chatting
studies people who are immobilized whole body, just getting a vertical and switching the weight from one leg to another actually preserve the level of bone density. As opposed to just laying down. So mechanical work.
Yeah, my patient, I do take care of about 5 paraplegic patients in my practice, and one gentleman who's 25, he had 30% reduction in his spine in 2 years, despite getting a dose of reclass because of the lack of weight bearing.
Are there any guidelines to screen paraplegic patients? Or was he just screened?
So it is recommended to screen because, I don't think there's anything formal, but definitely the bisphosphonates, there are a number of papers which have been looking at that drug. But so I did give him bisphosphonate, but when his bone density got reduced by 30%, I actually changed it up to, he just got approved for abaloparatide.
Because in somebody like that who's only 25 and in 50 years of bone health, that would be a very different paradigm from somebody who's 65 and we're looking at 20 or 30 years of bone health. So,
yeah, and also when I brought his case up at the Santa Fe Bone meeting this past fall, there were suggestions to also measure his radius. So I might include that. But basically, there's a basic multicellular unit or BMU. These are discrete packets in the skeleton. And so there's local regulation of these units. And then, you have this resorption of bone with osteoclast, then followed by the sequential formation of osteoblasts within the next 3 to 4 months. And so this is another schematic of that process. So basically you have the osteoclast will start initiating the resorption of the damaged bone. And then with time you form bone. And then the osteocytes do the mineralization with quiescent bone. So these are the main players. I think it's really, really key to understand how important the osteocytes are because they are more like 90 to 95% of the bone matrix. So these osteocytes are critical, and this is really where a lot of the signaling is occurring in the bone. But to be complete, the osteoblasts are the bone-forming cells, as I think we all know, and then the osteoclasts are the bone resorbing cells on the surface of the bone. So just to take a very brief overview of each of these three types of players. So the osteoclast resorbs, does the bone resorption, and they're multinucleated cells. They actually are descendants of the hematopoietic stem lines, very important with rank, and I'll get to that in a minute. And Dr. Sims from Australia, she's published quite a bit of research on this. Now, the osteoblasts are a different prodigy. They come from skeletal stem cells. And so these osteoblasts are the ones that build up the bone and then actually turn into the sequential osteocytes, the mineralized bone. And osteocytes are the most, like I said, not to be a broken record, but the most abundant part of our skeleton. 42 billion, and these are the central regulators of bone strength, and they have just cross networks, and you can see some of these beautiful pictures that show the interrelatedness of these osteocytes with the signaling pathways. So this is a very brief overview, but all the different types of proteins, expressions, and the components that help regulate bone in osteocytes. So, with that, I wanted to dive into medications. I think that's really as an endocrinologist, that's the key for us. And I wanted to start with the anabolic drugs. I think in endocrine, our job is often to give, like with our diabetic patients, is often to start like prandial insulin. I think with our bone patients, it's important to sometimes do the anabolic choice drugs. That's, I think, often where our role is best. We are lucky now to have 3 different anabolic treatments: teriparatide, abaloparatide, and romosozumab. So the teriparatide is the daily shot. It needs to be refrigerated. Teriparatide and abaloparatide both given at night because there can be some hypotension that can occur. So if you're sleeping, it's less pronounced. And the abaloparatide is an analog of PTHRP. It's not refrigerated. And the romosozumab is a monthly shot that is given for 12 months. Humanized monoclonal antibody to the sclerostin inhibitor with the WNT signaling. So basically, why does teriparatide help? It helps because there's quite a bit of formation of bone. So I often find that if you have a patient who has hardware, from prior discussions with Dr. Dempster at Columbia University, this can really be one of our best shots to solidify that hardware prior to neurosurgery in the spine. This can be very, very helpful because, like I tell many patients who I see in the office, you can have the best surgeon possible, but if your bone is essentially mashed potatoes, they're not going to be able to do much. So this can be very critical to starting, at least it's kind of unclear perfect duration, but at least 3 months prior to any spine surgery, it can help solidify the hardware. And you have these different formations on, particularly on the old bone. You make a new bone there, and these BRU, the basic metabolic units, can really be improved with new bone.
Would you prefer teriparatide over neoplast in patients like you mentioned?
Yes, greatly. And so I didn't realize how important teriparatide is to the neurosurgery patients, but we invited Dr. Krishnani to come speak to us, one of our calcium webinars, and he said with teriparatide on board, he is essentially able to offer a different type of surgery to the bone patients, to his neurosurgical patients, because when he used to split the skin of the spine, people's bones sometimes just collapse. With the teriparatide, he can appreciate markedly improved bone strength, so then he can offer them better surgeries and.
So you do the whole 2 years and then operate or not?
3 months. 3 months.
3 months.
Yeah, if possible, but of course, individualized. Yeah, sometimes it's hard to get these drugs covered because.
I know. I mean, I try to kind of keep this using relatively sparingly like some cases because of the limitation, like that limitation. Something I don't want to spend it on what's absolutely necessary. Maybe I should be a bit more aggressive, but in this case, pretty.
And so the improvements with this drug is, the seminal paper was near it all in 2001, New England Journal. I mean, you have the pronounced reduction of vertebral and non-vertebral fractures. It's been approved for women with prior vertebral fractures, glucocorticoid-induced osteoporosis, male osteoporosis. I will dump in my smart phrases into our new registry so that I can contribute. And I also have letters that have already been written, so you can quote them to get these drugs covered. I think that because of the Vero trial, the sequence of this is really important. You want to build up the bone before then you prevent the reabsorption. So really look at, there's one take-home point today, really look at your patients and see if maybe an anabolic agent would be most beneficial for them. I think with the fellows, we've been doing that quite a bit. Abaloparatide is actually, based on the PTHRP receptor, and it actually has better data than the teriparatide because you have a higher ratio of the anabolic-catabolic pathways. So you have really tighter signaling and improved bone density. Unfortunately, and I hate to say this because I looked at this during my fellowship project, and I was involved in some of the trials with this, but I have higher side effects with these drugs, the abaloparatide compared to the teriparatide. So the hypotension can be really bad, and also the tachycardia. So although the data is actually stronger for abaloparatide, because there's a better binding of the abaloparatide to this PTH1R receptor, I find that actually patients are not able to tolerate it. So I'll do like the prior auth paperwork, and then we'll get it approved. And then after a few doses, the patient will say it's like really impossible to take it. So I do start with teriparatide, although the data is actually a little bit stronger for abaloparatide. But you have very nice improvements in the bone density. With abaloparatide, the line in orange, you could see the higher density with that drug. And
2 years, or this is timeline? I don't see that.
So yes, I believe it's 2 years, but I'm not 100% sure. I should check.
So these agents don't help as much with the wrist, though, right? Like if your biggest problem is the wrist, these would have to be the best agents.
Correct.
Yes.
Yeah.
I think Dr. Khan, so I have a patient who has a low wrist BMD but good spine and hip.
Right.
So I think I discussed a couple of cases with you where then we gave an option to the patient and she decided just to watch it.
Yeah.
Because the medications don't help.
Yeah, it takes a long time to really improve the wrist. I talked to Shobak in UCSF, and if you've already done parathyroid surgery, you may not really see big improvements, and so sometimes I don't take that into account.
Also, if you break your wrist, you're not gonna die. If you I'm gonna spine much more.
And then this is the reduction. This was actually 18 months. So I'm sorry, this was actually 18 months, not 2 years.
18 months.
Yeah, so there is improvement in fracture rates with the abaloparatide. So the data is stronger for abaloparatide, but the side effect profile, unfortunately, I found it to be like much worse. Now, romosozumab is the newest kid on the block. So basically, individuals without sclerostin, had a very high bone density and had a very low risk of fracture. So basically, they were able to use and manipulate this condition to use in a drug called romosozumab. So the data shows that actually with 12 months of this agent, you have the maximum bone building capabilities. This drug is unique because not only do you have bone building capabilities, but you also have reduction in osteoclastic activity too. So it's a dual mechanism, which I think we've discussed like several times in our ESAP sessions. So this is really great medication, and we have nice improvements in bone density with this drug, and you can use it for 12 months. You do have to come in to the office to get them, so that could be a limiting issue. Usually the side effect profile for these are minimal. I do check a calcium at baseline and then at 6 months and a year, but these are not actually like there's no real guidelines to how to do that. But that's what we've kind of picked. And so you can have really nice improvements at all 3 sites. And so Felicia Kosman, who I think will be joining us this summer to talk to the fellows, has done some nice work on romosozumab from 2016, and you could see the reduction in the fractures. And you have this really unique mechanism of bone formation and also bone resorption. That is, the bone resorption is reduced and the bone formation is markedly improved. Any questions?
Since you're showing the bone markers, how do you use that in clinical?
So that is a challenging question. So in patients, first of all, I think the group, so let me repeat the question. The question was, how are bone markers used by me? Some individuals use them quite a bit at other institutions. Our assays have recently been kind of revamped. So I don't have a way to compare prior bone markers to current bone markers. But basically, if you're not sure if the patient is taking oral medication, you could do bone markers because they should be low in bisphosphonate use. And oftentimes people will, like 67%, I think, of the time after 3 months will just stop taking their alendronate completely, so you can kind of get a good sense if they're on it. You can also see if they're on a drug holiday, if the drug holiday is continuing and it's still working. So that could be another way to know.
When do you check for the drug holiday?
I do the CTX because that's the one we have.
Urine CTX?
I'm gonna say blood. We don't have it anymore. Yeah.
I have more than a long time now.
Yeah, so we do not have NTX anymore, unfortunately, but we do have CTX. Yeah, the range is quite large, and there are a lot of variabilities like time of day, fasting, non-fasting, stuff like that. So
I don't know if you have it in the presentation, but if you can talk about the drug holidays at some point.
Yes.
Yes.
So I did want to move to the anti-resorptive treatments. And so these are the most commonly given treatments. So denosumab came out in 2009. So it's a potent inhibitor of the osteoclastic differentiation. So it's the first biologic drug to treat osteoporosis. A lot of concern initially about infection. There's been very minimal data showing that there's any reduction. That there's any change in infection rate. For some people who had literally active infections, I don't use it because discussions with infectious disease has resulted in high level of concern. But I mean, for most people, there's really no issue with infection. It's very safely tolerated. I do not get like a baseline dental exam clearance from the dentist. I think that really delays things. I think if you talk to your patient, say, do you see the dentist? Do you have any like cavities? Do you have any root canals that need to be done? They're usually quite honest. So I don't get a formal note. I think that can really kind of put a wrench into your plans. It's a very, very potent anti-resorptive agent, and there's also some new data now that shows that there's some bone building properties as well. Please My second take-home point for this talk would be do not stop this without, putting them on another drug, because basically you're covering up the RANK ligand receptor and you have all these osteocytes around. And so after 2 or 3 doses, you're going to, if you stop the Prolia, if the denosumab is withheld for another reason, due to scheduling, et cetera, then you can have a high risk of vertebral fracture. And my patient who went to a wedding and forgot to reschedule her dose ended up having like 3 vertebral fractures out. She fell in her bathroom. So you can transition. Dr. Ramchand has looked into that in a lot of the work she's done, and that could be a topic for another day. But basically, transition, maybe give a dose or a couple doses of zoledronic acid. But this is a very, very effective drug. If the patient can make it to the clinic, because unfortunately in the United States, you generally need to come to the clinic to get this drug approved, you can have nice improvement in bone density. This was the Freedom Extension study. So basically, these are pictures I show my patients. I think the fellows know that who work with me. But basically, the line in blue are the people that took denosumab. Took denosumab for 10 years. So you can have improvement of 21.7% in the spine. And I'll show some of the other data in the hip and the forearm. This is the people who took calcium and D for 3 years, and then they were transitioned to denosumab and they added 16.5%. So you have very, very nice improvements in density at all 3 sites. I'm sorry, I thought I had pictures of all of them, but basically you have 21.7% in the spine, and you also have about 10% in the hip and also 3% in the forearm. So this is a very nice drug, but you do not want to start it in someone who's relatively young. Of course, the age of being young always depends, but I mean, I would never start.
Depends on how old you are, right?
Yeah, exactly, depends how old we are. I mean, I would never start it in someone in their 20s, unless there are particular circumstances, such as maybe being a kidney transplant and not having any other option, and then transitioning over maybe after their transplant. But I would generally start it in people who have good access to the clinic. I always make it most convenient for them, if possible. So I don't want them to plan on coming here, like driving 2 hours, because that's just not going to work. And so pick the Cleveland Clinic site that is nearest to their house. You can often order a therapy plan now or a CAM order, and you can get it in almost every single hospital, I'd say, in Cleveland Clinic at this point in time.
And a lot of kids.
Sorry.
I have a lot of East Side patients that live in Twinsburg.
Yes. So Twinsburg, we have a huge place. Willoughby, huge place. I mean, literally every single place. You call the appointment center. I don't know if people are aware of this. You call the appointment center. The patient will arrange their shot. Always the patient should have their next appointment before they leave that day, because you do not want to have, calling and missing the doses. So I do want to stress that. And, if they have dental work, this is not a huge deal. This is not like, a soap opera or anything. You just kind of do it in between the shots. You work with the dentist, the endodontist. You'll find different, the ADA, the American Dental Association, has put out recommendations about osteoporosis medications. And, you can do treatments in between shots if needed. So basically, unlike the bisphosphonates, and I'll go through the bisphosphonates next, but there is some modeling-based formation of the denosumab, which seems to be why you get some really, really nice improvements. But they're, basically, you're going to have all these inactive osteoclast precursor cells around. So as you go year by year with all these denosumab doses, you really want to make sure that you don't have any lapse in their treatment. You have about a month to play with, but after a month, they really need that dose. I think there's some questions in the audience.
Oh, there's some background noise happening. I think some of it is us talking that's showing up as background noise. Just repeat the questions.
Okay. So basically, any questions about denosumab, and everyone knows to continue it every 6 months. It is lifelong. This is not like a novel concept. I mean, when you start a statin for cholesterol, you do it generally for the majority of their life when you start a blood pressure agent. So, I mean, this whole notion of, oh, it's lifelong, I think is really not a big deal if they have good access to the clinic. I will say one thing though, for people who are snowbirds, because we do have many snowbirds here who travel to Florida, it has become almost impossible to, Florida has become almost impossible for me to order. So this drug. So in the past few years, I was able to just give them a note and they could go get it in Florida. Now there are actually requirements for most people in Florida that you have to establish with an endo there, which is like extremely hard. Because there are very, very few endos in Florida. If they live near Weston, you can do it easily.
Yeah.
We have a question in the chat. If you stop Prolia in someone with renal insufficiency, what do you piggyback with?
So the question is, if you stop Prolia with someone with renal insufficiency, what do you piggyback with? Very, very hard question, because the thing is the bisphosphonates are renally cleared, so you can't really use them. Although there are some like case reports about using them. So with some of the work that we've been doing, Dr. Gosman and Dr. Lansing and I with the Abu Dhabi team, we've thinking more like you do a couple doses of Prolia, they get the transplant, and then maybe use a bisphosphonate to solidify it later on. But yeah, that's really a challenging question. So some patients with renal insufficiency, if denosumab is not a good option, I oftentimes will sometimes do calcium and D, which really doesn't feel very satisfying, but.
So treating yourself instead.
Yes, exactly. Yeah. So this, I think, is important to mention that the BMD change does predict fracture risk reduction. So, because if you have to show fracture risk reduction, you would need thousands and thousands of patients. There is kind of a change in our literature now to show BMD change instead of necessarily fracture risk reduction in our literature, because it's a little bit easier.
We do have another question. What is known about the mechanism for morphological gender differences, particularly regarding pelvic shapes? Maybe you can answer it.
Yes, I'm not really aware of the pelvic shape differences, like regarding fractures. There are differences with gender, but maybe I could do it at the end. So this is a schematic kind of looking at denosumab and how it works. So you have, with time, how you, have the involvement of the osteoclasts and osteocytes and some bone building properties at the end of the 12 months. So bisphosphonates are really the backbone of our treatment for osteoporosis. These have been around. A lot of the early work was done by our own Dr. Licata in the 1990s and late 1980s. And these are really the backbone of osteoporosis treatment. As I alluded to earlier, osteoporosis treatment, if the anabolic drug is felt to be helpful, you do want to start that first, because if you start the anti-resorptive treatment, then you have blunting of the anabolic agents later on. But given that if you want to start a bisphosphonate, keep in mind that it's incorporated into the bone and it stays there for many, many years. And so it can be a very, very nice treatment. Most people do not take the oral treatments as they should. Unfortunately, they kind of just stop it, as I already mentioned. So for that reason, I do use quite a bit of zoledronic acid, which is an infusion. It takes 30 minutes to give, and it's once a year. There are flu-like reactions, which I find to be the worst side effect of this drug. You can give steroids if needed. I've only given like 2 in 15 years to give you an idea of how rare that is necessary, but 30% of people do have some flu-like symptoms. And so I typically don't really give it like right before a big event for the patient. Sometimes they'll get it on a Friday, but they do bind strongly to the bone mineral, and they basically act on the osteoclast so that you do not have as much bone resorption.
So zoledronic acid is actually the oldest of these phosphonates, which was not approved for osteoporosis because it was for the human hypoglycemia malignancy originally. First one approved for the osteoporosis was fosphonate, 1995.
I actually did a poster with Dr. Licata when I was a fellow about using lower doses of zoledronic acid than 5 milligram, like 3 milligram, in some patients to see if it happened. I was too lazy to write the manuscript and now I regret it. At that time we had a poster that had to wait.
And a lot of these are actually in part of the breast cancer protocol, so it's important to remember that. And you know, there is data in breast cancer literature too. But basically, these are very significant anti-fracture drugs, and you can really reduce vertebral fractures of a very wide range of 40 to 70%. In other places, 25 to 40%. So these are good drugs. These are solid drugs. Some people do have apprehension about doing an infusion. I think psychologically they think that they're going to have side effects for an entire year. Usually you do not. It's just like a few days. But you know, if someone wants an oral drug and they really want to take it every week, you could definitely do an oral alendronate. You can also do once a month treatment, oral risdiplam. The oral abandronate doesn't really have known data at the hip, so I try never really to do abandronate since we have other options. But probably helps at the hip, but it's never been shown. In terms of the infusions of the abandronate every 3 months, I've never done that because I think it's way too time consuming and unnecessary.
Yes, yeah, and it's like much more complicated because infusion has to be much longer. It's like not 25, 30 minutes, it's like hours. They're 4 to 24 hours, I'm saying, so it's not simple.
Yes.
And it's every 3 months.
Yes, every 3 months, and it is several hours. I do have like a couple of patients that only could do the intravenous pamidronate, like 2 of my patients, so they get it every 3 months. They're unique cases. One has osteogenesis imperfecta, and so she can take a lot of doses, and the other one is paraplegic. Anyways, basically, these are. So the question was, do you recommend that everyone start with anabolic? So, I do not recommend everybody start with anabolic. You really want to kind of risk stratify your patients. So in the office, when you're looking and talking at your patients, you want to get a sense of their clinical fractures, their genetics, any secondary fracture, any secondary osteoporosis that can be treated. If they are having very low scores, you do want to consider anabolic, or if they've had clinically many fractures, you do want to consider anabolic. But I think you want to consider anabolic more than maybe we as a group do, but I definitely don't offer it to everybody.
It is interesting when I did the ESAP questions in 2020, a lot of the answers were reclassed and not denosumab at the time. I don't know if in the last 4 years that thought has changed more. Like the questions have veered more towards anabolic, but 4 or 5 years ago, most of the questions were more towards anti-disruptive.
I don't know. I will be able to tell you as I continue this study from my course. They're very expensive, these anabolic agents. And, basically, I think a lot of the companies just say immediately decline them. So I would prepare your patient that they'll be declined. And then if you just use the repository of the smart phrases, you can, quickly use one of those phrases. And then if you do the second or third time, I usually have no problems getting it approved, to be honest. But basically, this is showing a cartoon of how the bisphosphonates work differently than the denosumab, where denosumab works on the rank ligand receptor, and this works on some of the phosphate protocols. And just as a side note, I had a patient recently who was given a bisphosphonate for tumor-induced osteomalacia. So please, in your evaluation of your patients, please check the phosphorus, because the phosphorus was actually almost undetectable when it was checked. And so if you check the phosphorus as part of your workup of everyone with bone issue, then you can catch those patients who may have XLH or TIO. But basically different mechanisms of the bisphosphonates and the denosumab. And the bisphosphonates, you only need a couple doses. So if you're looking at someone in their 50s or 60s, I find this to be generally a better way to go than a denosumab, because as I said already, the denosumab is lifelong. The other thing is that you only need a couple doses oftentimes, and then you could do a drug holiday, because with 10 or 15 years of these drugs, there is a very low incidence of atypical femur fractures. in the femurs, which is a radiographic, very specific radiographic diagnosis, and osteonecrosis of the jaw. But every single patient I see is pretty much worried about those issues, and so a drug holiday can be helpful for those things.
Dr. Khan, do you have a smart phrase that all of us can use that talks about that atypical fracture risk for patients who are starting on reclass?
Yeah, I do have a smart phrase. Yeah.
We can, for everyone on the call, we can include it in the repository so that you guys can use it in your clinics. We will all cheat off Dr. Khan. And I think there's a question in the chat. If you could.
Yeah, so after surgical, so I will be putting a lot of the phrases into the repository so you guys can help yourself to those phrases that I use if they're helpful. So basically, after surgical repair fracture, how soon may you restart osteoporosis therapy? So this is a controversial area, and basically, some places do it like 2 weeks later. I haven't found really robust data not to start it shortly after, like 2 weeks later. So I think that would be fine. I think it's hard for me to generalize, which agent. I would kind of look at the patient and see which drug they're on first, and then kind of customize it afterwards to see if that's still the best agent. It's hard for me to generalize for today's topic which one I would use.
Wait longer, usually 3 months. Yeah, but I mean, it's osteoporosis, slow process,
It's hard to do.
2-3 months.
There's no data, I guess.
Yeah.
And
That's what I tend to do. It's not.
What would you avoid? Is there something you avoid?
And Dr. Ramchan did want to mention to do it as soon as possible because you don't want to forget. Almost the data for people who get treatment for osteoporosis is like abysmal after a fracture. Pretty much nobody's getting any treatment after a fracture. So keep that in mind when you're looking at your patient. And I'm sorry, what was
The other question is there something you would avoid after surgery?
Avoid
In terms of agents. Avoid.
So there are no agents that I particularly avoid after surgery. I mean, the thing is, if you're doing surgery and you're putting hardware in, the teriparatide is really my go-to because it will help with the healing.
That's true.
Okay, that's good to know. And if we can all figure out, Dr. Khan is there to send patients to.
And also there are 4 others. So Dr. Williams, Dr. Ramchan, Dr. Husney, and Dr. Gosman.
I do a lot of bones too.
And Dr. Scuber. So basically, in a nutshell, these are kind of different ways of suppressing osteoclastic activity. So the Wnt beta-catenin pathway is with the ROMO, the RIG ligand was denosumab, and you're looking at incorporation of the bisphosphonates into the bone is your bisphosphonates. So there are different ways to kind of reduce the osteoclastic resorption. And I think, now in 2025, we have a lot of different agents that we can use in our armamentarium of drugs. So, do your evaluation, check the phosphorus, look at the alk phos as well, make sure they don't have hypophosphatasia, because if they do, then you could give them aspartase alpha. Check for secondary causes of osteoporosis too. Make sure their celiac disease is diagnosed if they have that, or vitamin D deficiency, or eating disorder. If that is there's eating that's a problem. Sorry. Or hyperpara for sure. Hyperpara, by doing the surgery, you get amazing results of the bone. I found. Encourage your patients to do exercise, in a very careful fashion, so they don't cause any problems to their bone.
There's a physical therapy osteoporosis.
Yes, there is the physical therapy for osteoporosis, which I've started ordering quite a bit.
Do you know what the order is called? Just for
You have to go to physical therapy, orthopedics, osteoporosis.
So there's a drop down that
Yes.
we can use.
Yes.
Can you repeat?
Yes,
that?
so the question was how to find the physical therapy for osteoporosis. So you go to physical therapy, then you go to orthopedics, and then you go to osteoporosis, and you can order physical therapy for osteoporosis. And you can really get these patients to move around. I have personally been unbelievably impressed with with exercise, how that helps. But exercise, when you're dealing with someone who's had a fracture, who's very low T-scores, is not the only thing. You have to also do pharmacologic treatments and make sure their calcium and D is managed too. So the calcium ideally is in the diet. If they can't do dietary calcium, then add the calcium in the food. I'm sorry, tablet form, and then make sure that they get vitamin D repletion too. So yes, Dr. Zimmerman.
So the rosacimab, there was a lot of discussion about its increase in cardiac events and things like that when it first came out. How do you take that into account?
Okay, so great question from Dr. Zimmerman about the cardiac events with romosozumab. So I did not mention that today. So the romosozumab works on the sclerostin inhibitor, and because sclerostin is in the heart, there is definitely increased in one of the studies. There was an increased incidence of cardiac events with sclerostin inhibitor. So basically, if you're going to give someone, that's a great comment. So if you are going to give someone romosozumab, you do want to ensure that they have not had a cardiac or stroke event in the past year. Personally, if the patient's had a stroke or a cardiac event in the past few years, I wouldn't give it either. There was a debate at ASBMR in 2023 if this is a real phenomenon or not. Personally, didn't seem overwhelming to me, but I've discussed with other colleagues in the Calcium Center, and they do feel that it is of concern. So, there is a black box warning if you've had a cardiac event, and not to give in the past year, not to give the romosozumab. So that's a very important point. Thank you for bringing that up.
Can I ask the question from the chat? Is there a T-score threshold you're looking for on follow-up to suggest therapy is working?
So there's a concept now. So the question was, is there a T-score to show that therapy is working? So I think that's a very important question. First of all, we don't compare T-score to T-score. You compare grams to centimeters squared because the T-score involves age. So you can't compare T-score to T-score per se. You have to look at the grams per centimeter squared. Many patients, and I think also clinicians, kind of anticipate that the scores will bump up. If you maintain the grams per centimeter squared, in my mind, that's a win. So by maintaining your bone density, that is a win. Please don't look at the T-scores. Please look at the grams per centimeter squared. There's the concept of treat to target. So the goal kind of now is to try to get all these patients from osteoporosis into osteopenia or normal if possible. But that's why you kind of order a treatment that could kind of pull you out of that osteoporosis range. But maintaining density is a win, and there's no cutoff treatment.
Before I leave, I just want to say something. So we were talking about these paraplegic
Yes.
people. So I remember reading the studies, there was this vibration therapy.
Yes.
Actually, there was several studies showing improvement, some studies showing no improvement. So maybe there was something that can be done in those patients.
Yeah, so the comment from Dr. Struger was about vibration therapy, and that actually was, I think, approved now for osteopenia. So there's a vibration device. So that's a very important thing. I'm not aware of the data on that. I should look into it.
But for a paraplegic patient, that would be where because other people can exercise.
Yes, yeah. So that might be a very useful thing for paraplegics. I know in the dental arena, they do use vibrations to kind of have healing of. So it might be very much worth it. Yes.
Can I comment on the question? There's a big area around litigation, post-fracture and bone health in the UK. That's a service that we have developed specifically to pick out people from the orthopedic to become a big area. It makes me think we could maybe use some of the smart phrases for consistency. If you had a big,
We will share the repository with you.
and the other thing I wonder was when we take super fit people within 0G for 6 months, rules. There's any sort of work done on this repetitive movement, maintaining bone health, give them a shot at this when they come back after a year.
Yeah, so the comment, first of all, was that in the UK, there are litigations for individuals who don't get any treatment for their osteoporosis. I hate to encourage litigation, but maybe that's the only way we'll get some improvement in the United States if we start litigating. I can't believe I'm saying that, but the second comment was regarding being in space. So because we do have a NASA Space Center in Cleveland, Dr. Licata And I don't know if he's on the call today, but he did do quite a bit of work on patients in their without gravity and their bone health.
Thank you. Please comment on thoughts on calcium and vitamin D use, and are men treated differently with drug therapy?
So calcium generally, and I do have a very nice smart phrase. The question was calcium and vitamin D. That was the first part. So I do have a smart phrase on the calcium and D. So generally it's like 1,200 per day based on your age, or 1,000 if you're a little bit younger. I think 50 is 1,000 milligrams a day, 1,200 for a little bit older individuals. So I always try to do it in the food. The exact amount of vitamin D is always controversial on kind of just a simplistic basis. I do like 1,000 or 2,000 a day. Most people who don't have an intestinal absorption issue. If you can't do the calcium in the food because of ethical concerns or lactose deficiency or just inability to eat any dairy, then you can dip into calcium. Calcium citrate is better absorbed.
Men treated differently with drug therapy. I think you showed something with teriparatide already.
Yes.
But what about the others?
So the second part of that question was drug treatment for men. So the romosozumab in the United States is not approved for men. So the patient that I've already mentioned, who was a paraplegic, who had 30% of loss in his spine, I did try to give romosozumab. It was denied. I tried extensively. This was the first denial that I've had in like 5 years. I was very disappointed about that. The romosozumab is approved in the UK and in Europe. And so we are anticipating that romosozumab will shortly be approved here. It actually depends on one thing, if that the FDA, if it will be using the fracture data or if it will be using the change in BMD. So if they do the BMD change, then hopefully then it will be approved quickly. If the FDA insists on having fracture data, then we will need a very, very large study to show the reduction in fractures.
Is physical therapy for osteoporosis that we mentioned, do you know if it is covered by most insurances?
So the question is physical therapy covered by most insurances? I've never had a problem ordering physical therapy. And so I think it's always worthwhile, but you never know, some of these insurances don't cover anything.
Can you comment on vitamin K with vitamin D supplementation?
So the question is regarding vitamin K. So vitamin K, as everyone knows, is involved with clotting. So I try not to, as a rule, kind of encourage people to do vitamin K, although it is very much like discussed in the lay press. So I personally do not encourage vitamin K because I'm not familiar with the literature around that. But yeah, many patients will ask me if vitamin K is the way to go. I always say, at this point, I don't have data to support its use.
Okay. There is another question. In what situation, if any, would you use dual therapy? Denosumab with teriparatide.
So the question is of using denosumab and teriparatide. So we are lucky to have Dr. Ramchan in our department now, who worked, I think, on some of this data with Dr. Benjamin Leader at Harvard Mass General. And so I did use dual therapy because I see some intestinal transplant patients, and basically the team tells me if the bone density doesn't improve, we are not transplanting them. So in desperate measures, I have done that. It actually did help quite a bit. This was actually prior to romosozumab advent. But yeah, I did do that and it worked really nicely. So that is an option for people who you're in a really tight situation, because basically it will be coming down to me to be enabling them to get a transplant, unfortunately. So that can really help.
Does the insurance approve that easily? Using both?
So the question was, does insurance approve it? I actually got it to be approved. I think you'll find that basically they just say no, no, no. And then if you keep pushing, everything will open up.
Okay. Is there any data on OsteoStrong alone?
Okay, so the OsteoStrong is a physical therapy. It's kind of like a franchise. So OsteoStrong is like a franchise. You go to these different sites in the United States, I believe, and they do exercises. They do weighted exercise. So my gestalt on this, first of all, there's like no data on the OsteoStrong, but basically each franchise is a little bit different. And so I don't have fracture data from like franchise in Mentor versus a franchise in like Pittsburgh. So I don't really have very robust data to go on. I think if someone, wants to do exercise, I would encourage them. You can get Medicare to pay for OsteoStrong. And I'm happy to write a letter for people who want to go to OsteoStrong. I just tell them, please be very careful. When you go, don't do anything that feels uncomfortable to you. Make sure that the person you're working with is good. Dr. Viukas said a lot of people in Chagrin are seeing really nice improvement on BMD. I think it just goes along with showing how exercise helps. So if you have a patient who's pretty savvy and who really wants to commit to OsteoStrong, I think just like any other exercise, it's helpful. I think the goal of the OsteoStrong is to have gradated improvement in weight training.
I think you emphasized a very good point, and which is something we see in our obesity patients as well, who hire trainers. That trainers push these people to lift heavier and heavier weights. And some of them have ended up with a lot of shoulder and rotator cuff injuries because the trainers don't realize that this gradation has to be done so slowly. So I think that's a very good point. And I presume OsteoStrong is like Orange Theory, so it's no insurance coverage and such.
Oh, no, if you write OsteoStrong, if you write a letter for someone in Medicare, they apparently do pay for it.
Oh, they do? Oh, wow. We didn't know that. I think that would be something important for some of our patients, that if Medicare covers it, they can use it.
Yeah, so I think it is a very, very expensive treatment if you don't have coverage. But if you can give this letter, I think it does reduce the cost to a very manageable amount. It sounds like probably the one in place in Chagrin is doing a good job. But yeah, you want to make sure that the person you're working with isn't pushing you too much.
I think we're going to cheat off Dr. Khan's a lot. We have 2 minutes left, but I think there are a couple more questions. Dr. Khan, if you want to just go through them.
So the question is, if a patient has severe infusion reaction to first IV bisphosphonate, would you prescribe medication? Yes, I would do the steroids, Medrol dose path. That can be very, very helpful. That inflammatory reaction can be really, really bad. It's usually for the first dose. You can actually have a reduction in those infusion reactions if you give Tylenol. So that is part of our protocol at Cleveland Clinic to give Tylenol. The second infusion actually usually goes much better. So if the patient is open to getting a second infusion, some of these patients are, I wouldn't really hesitate. For the OsteoStrong, there's a $199 fee to join, and then another $200 every 3 months. So that's the cost of it.
There's one before the infusion one.
Since most of us don't do bone biopsy, what is the cutoff for PTH and bone alpha, which you're confident it's not adynamic bone disease in CKD patients? So the question about adynamic bone disease is very complicated in CKD patients. I think there are like 6 different types of bone in CKD patients. So I am not familiar with how to know if there's adynamic bone disease present or not. I'm very hesitant to use treatment in CKD patients. You have to get severe hypocalcemia with denosumab, severe. Like one of my patients couldn't move her neck for 1 week. So I am actually terrified of denosumab in people who have very low renal clearance. Also people who don't have good intestinal absorption of calcium. I'm also kind of terrified of those patients. Everyone else, I'm usually okay.
Okay. I think we are at 8 o'clock. Thank you so much, Dr. Khan. This was absolutely amazing. We're going to put this on our YouTube channel. I think the questions just by themselves were absolutely amazing. As we have a wonderful growing calcium center, so please don't hesitate to send patients or send the emails to Dr. Khan if you have cases and questions. Thank you very much, everyone. We'll see you next week.